So let's get started. Agents to control blood glucose levels. Diabetes. Diabetes is a complicated disorder that alters the metabolism of glucose, fats, and proteins, affecting many end organs and causing numerous clinical complications. Talk about the pancreas. The pancreas is both an endocrine gland and exocrine gland, okay? The pancreas is both an endocrine gland producing hormones and an exocrine gland releasing sodium bicarbonate and pancreatic enzymes directly into the common bile duct to be released into the small intestine. So you guys are learning about the pancreas in diabetes. You're going to learn about the pancreas again in when you guys do med-surg GI. You're going to learn about the pancreas again when you get to peds and we're talking about cystic fibrosis. You're going to see the pancreas in different body systems. This is both an endocrine and an exocrine gland. Next page. The endocrine part of the pancreas produces hormones. This is the second time they're telling us this. The endocrine part produces hormones in collections of tissues called islets of Langerhans. The beta cells in the islets of Langerhans, that's where insulin is made. So if the patient has a problem with the pancreas is not functioning properly, they're going to have problems with glucose because, again, insulin's made in those beta cells in the islets of Langerhans. Okay? Insulin. And I wrote it up here. I couldn't find it in the book, but it's important for you guys to know you are definitely going to be tested on that. When it comes to insulin, your patients that are type 1 diabetics, they're insulin dependent. They absolutely have to have an exogenous source. Remember that word exogenous means from the outside. They have to have an exogenous source of insulin to survive. They will die if they don't get that. Either the pancreas is not working at all. Remember, the pancreas is responsible for making that insulin. Either the pancreas is not working at all, or the pancreas is working at such a minute level, it's not making enough insulin for that patient to survive. So if the patient has type 1 diabetes, they are insulin dependent. They can't take an oral hypoglycemic agent. It has to be insulin. Are we clear? All right. Insulin is the hormone produced by the pancreatic beta cells of the islets of Langerhans. Next page. Insulin also stimulates the synthesis of glycogen. That's glucose stored for immediate release during times of stress or low glucose. Insulin is released after meal in response to incretin release and when glucose levels rise. So let's talk about this, and it makes sense. If you just ate a large meal, you just ate a small meal, you ate a snack, that's going to bring up your glucose, right? So your body's going to try to survive no matter what. So you have a meal and your body's supposed to release insulin to lower that blood glucose. As a result of the insulin release, blood glucose levels fall. Insulin is the key to get all of that glucose that's trapped in the blood, is the key to get all of that glucose out of the bloodstream and back to the tissues where they belong. Because if the glucose is in the bloodstream, it's not effective, it's not doing anything. It's the tissues that need the glucose for energy and to survive, right? Let's talk about glucagon. What did I write here on the side? I wrote teach family members. Okay, teach family members if the patient passes out at home, give them an injection. If that patient has passed out, why would you put anything in their mouth? They can aspirate, they can choke, right? So if that patient's a diabetic, you're going to give them an injection. You are not going to give them glucagon. You're not going to give them anything. You're not going to glucagon. You're not going to put anything in their mouth. So, you know, if a patient's a diabetic, for example, they have a hypoglycemic reaction and they pass out. Are you going to give them orange juice? They're passed out. Are you going to give them a piece of candy? No, you're going to give them an injection. So Glucagon is released from the alpha cells in the islets of Langerhans in response to low blood glucose levels. Glucagon causes an immediate mobilization of glycogen stored in the liver and raises the blood glucose levels. Let me ask you guys something. Which is more deadly, hypoglycemia or hyperglycemia? Hypo. Very good. Very good. A person under stress will have increased glucose levels and increased free fatty acid levels, which will provide the energy needed for the immediate fight or flight associated with the stress reaction. And remember, guys, illness is a form of stress. So something very important for you guys to know, I see it on test questions all the time. They'll give you an example about a patient who is not, who is diabetic. They're type 2 diabetic. They've been managing their diabetes on diet, exercise, and oral hypoglycemic agents, right? Now they're in the hospital for whatever reason. God bless you. They're about to have surgery. They're in the hospital and they're getting insulin. And this patient's now in tears. They're crying. And you, the nurse, walk in and you say to the patient, well, you know, what's going on? What's wrong? And the patient is crying and saying, you know, now I'm on insulin. I have to take injections for the rest of my life. Your job is to educate that patient and say, that's not necessarily true at all. During times of stress, your glucose goes very high. And so you need insulin because obviously you're in the hospital, you're sick, your body's under stress. But when you go home, you're most likely going to be able to go back to your oral hypoglycemic agents. You have to know that. You have to be able to teach that to the patient, okay? Box 38.2, glucose control mechanisms. Make sure you know them. The ones I put a star next to are the ones that you see on test the most. And what, guys, when I tell you see on test the most, I mean on the big exams, such as NCLEX, such as HESI, such as ATIs, right? And you know I test following them. So anything that they ask a lot, I'm gonna ask. So look at this, insulin. It decreases blood glucose, glycogen storage, adipose tissue deposit, synthesis of proteins to form amino acids. Glucagon increases blood glucose. Catecholamines, they decrease insulin release, increase glucose output from the liver and muscles, and increase the breakdown of fat to FFAs, that's your fatty acids, your free fatty acids. Corticosteroids, they increase glucose output. Oh, thank you. Sorry. They increase glucose output and decrease insulin sensitivity. Loss of blood glucose control. Hyperglycemia or increased blood sugar. Hyperglycemia results in glycosuria. Glycose, sugar, urea in the urine, okay? Hyperglycemia or increased blood sugar results in glycosuria. Sugar is spilled into the urine because the concentration of glucose in the blood is too high for complete reabsorption. Because the sugar-rich urine is an ideal environment for bacteria, cystitis is a common finding. So those patients that chronically have high blood glucose, they tend to have UTIs. Remember, bacteria loves wet, moist, sugary environments. Polyphagia, increased hunger. Polydipsia, increased thirst. Those are signs and symptoms of hyperglycemia. So polyuria, it just explained that glucose in the urine, that patient has so much sugar in the blood, kidneys trying to filter that blood, some of that sugar is going to spill out into the urine. That's your glycosuria. Before I move on to polyphagia, a patient's going to have polyuria, excessive urination. Polyphagia, that's increased hunger. Let's think this through, guys. Why is this patient going to have increased hunger? Well, think about it. Remember I told you that sugar, that's what's feeding your tissues, right? But the sugar is stuck in the blood. So that patient's still going to be hungry for the sugar. They have enough sugar, but it's stuck in the blood. So they're going to have excessive hunger. But unfortunately, they're going to keep eating. They have excessive hunger, but all that sugar is still going to be in the bloodstream. What is the key to get that sugar out of the blood to the tissues? Insulin. Polydipsia, increased thirst. Yeah, they're going to have increased thirst. They're going to be so thirsty, they're going to want to drink water to try to dilute all of that sugar that's going on. Polyuria, polydipsia, polyphagia. Know those three. Those are classic signs of hyperglycemia. The patient experiences ketosis as metabolism shifts to the use of fat for energy. Remember, the body's supposed to be using sugar for energy, but it's not getting any of the sugar because the sugar's stuck in the bloodstream. So it starts breaking down your fat. Ketones are produced that cannot be removed effectively. Those ketones are the byproduct of the breakdown of that fat, okay? Acidosis also occurs because the liver cannot remove all of the waste products, acid being a primary waste product, that results from the breakdown of glucose, fat, and proteins. Muscles break down because proteins are being broken down for their essential amino acids. The breakdown of proteins results in an increase in nitrogen waste. This is primarily manifested by protein in the urine. Is there ever supposed to be protein in the urine? Absolutely not. Patients with hyperglycemia do not heal quickly because of this protein breakdown, as well as the lack of a stimulus to initiate protein building. Remember, guys, besides vitamin C, protein is very important to healing. So patients who are diabetic, they don't heal easily. One tiny little wound on the foot can turn into a big necrotic wound, and that patient has to end up getting that extremity amputated. They don't have enough of that protein for wound healing. And remember, they're full of a sugary environment. And bacteria loves wet, moist, dark, sugary environments. All right, let's talk about diabetes mellitus. Diabetes affects carbohydrate, protein, and fat metabolism. The most frequently recognized clinical signs of diabetes are hyperglycemia, that's fasting blood sugar level greater than what? 126. Fasting glucose level greater than 126, and glycosuria, presence of sugar in the urine. Next column. All right, let's talk about some of the disorders or complications from diabetes. Atherosclerosis. We got it right up here. I wrote effects. Oh, okay, effects of diabetes and NCLEX. Yeah, you definitely have to know these. Atherosclerosis. Heart attacks and strokes related to the development of atherosclerotic plaques in the vessel lining. Retinopathy. Resultant loss of vision as the tiny vessels in the eyes are narrowed and closed. I want you to think about this for just a second, guys. Think about your blood and how, it's supposed to flow freely to get to those tissues, to perfuse those tissues, such as your kidneys, your liver, your spleen, right? Now think about sugar being in that same bloodstream. You had blood that was free flowing, but now moving like honey, molasses. Think of how slow it's moving, right? That's number one. And number two, I want you to think about that thick, slow moving blood trying to get through those tiny, 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 tiny little vessels in your eyeballs. Of course, that patient's going to have retinopathy. And let me tell you a famous test question they love to give you on NCLEX. They will give you an example of a young person maybe, in their early 20s, that's a diabetic, and what are they at risk for? And they'll give you some crazy, diagnosis, and then they'll put in either the retinopathy or the atherosclerosis. That's what I tend to see the most. And they'll put a young person to throw you off. but it's because of the diabetes. Absolutely. We don't care how old they are. They're going to be at risk for these because these are the complications. Does that make sense? Mm-hmm. All right. Neuropathies, motor and sensory changes in the feet and legs, and progressive changes in other nerves as oxygen supply to the nerves is slowly cut off. Remember, guys, the oxygen is being carried in the hemoglobin, which is being carried in the RBCs, which is where? In the blood. So this patient with diabetes, when they have neuropathy, you know, you have to teach them before you take a bath, you need to test that water because they lose feeling. And so they won't know if something's too hot and they'll burn themselves. Nephropathy. We're talking about the kidneys. Renal dysfunction related to changes in the basement membrane of the glomerulus, where that filtration is supposed to be taking place. Let's take a look at this box down here. I put a big old NCLEX, so you better know it. Diabetes and blood glucose variations. Look at what it says. African Americans, Latino, Native Americans, Pacific Islander, and Asian Americans have higher risk for developing type 2 diabetes than white Americans. And that's usually given to you as a select all that applies, so you should know it. The clinical importance of this fact relates to proper screening of patients. So let's talk about screening of patients. Other groups that are higher risk have people who are overweight, obese, have a first-degree relative with diabetes, first degree such as mom, dad, brother, sister, history of cardiovascular disease, hypertension, hyperlipidemia, that's that high cholesterol, physical inactivity, being a couch potato, age 45 years and older, and women with polycystic ovary syndrome and or gestational diabetes mellitus. You see that whole group, everyone I just mentioned? People in these groups should be screened regularly for diabetes. So their annual physical should include that hemoglobin A1c. Let's talk about the hemoglobin A1c. Sometimes for testing, it may say hemoglobin A1c, or it may say glycosylated hemoglobin. It's the same thing. Make sure you recognize it, okay? Glycosylated hemoglobin levels or hemoglobin A1c test. This provides a 3-month, 90 days, 3-month average of glucose levels. Let me stop right there for a second. With that hemoglobin A1c, the patient can't trick you. Because what happens is they know they're going to see the doctor the next day, and most likely, besides the other tests, they might get a fasting glucose, right? And they don't want to hear about diet or exercise. So what do? The night before, they only have a salad. They have a salad early, go to bed, don't eat anything in the morning, so that when they go to the doctor's office, that fasting blood glucose, wow, 85, very good. Because remember, the fasting blood glucose is supposed to be 70 to 110, right? Very good, Mr. and Mrs. such and such. But you see that hemoglobin A1c? They can't trick you with that because it gives you a picture of what that patient's blood glucose has looked like for the past 90 days. So how is it that your fasting glucose looks so nice today, but the past 3 months has been through the roof? Okay? Red blood cells are freely permeable to glucose, and this test, the hemoglobin A1c, gives an average range of glucose exposure over the life of the red blood cell, which is 120 days. This test does not require fasting before blood is drawn or the oral intake of glucose before testing. That is a wonderful pro for the hemoglobin A1c. This is important for you guys to know. Elevations at or above, so equal to or more, or equal to 6.5% may be an early indicator of diabetes before changes are noted in the fasting blood glucose level. Once a baseline is established, the goal of therapy for a diabetic patient, hemoglobin A1c is less than 7. This is important. You have to know that. So if that patient is not a diabetic, the hemoglobin A1c needs to be less than 6.5. Actually, I'm lying to you. I'm lying to you. 5.7. Give me a second, guys. No, that's not right. Let me take a look because it's supposed to be, if you're not a diabetic, it's supposed to be less than 5.7. And then if you are diabetic, less than 7. Let me look in the book because I don't know why it's saying this. Where's that go?
Normal A1c is below 5%.
Exactly, but I'm looking for it in the book.
Oh, sorry.
No problem. No, I know that. I know it in my head, but I don't see it in the book. But you guys need to know that. I'll find it. But know that if the person's not a diabetic, it needs to be less than 5.7. Hemoglobin A1c. And then if they are diabetic, less than 6.5. I promise, I've been doing this for years. I'll find it in the book, but you guys need to know that. 5.7. If they're not a diabetic, it has to be less than 5.7. If they are diabetic, it needs to be less than 6.5. The note at the top, what did I write here? I wrote the number one way to determine compliance. If you want to know if that patient's been truly compliant with the diet and the exercise that they've been taught to do, look at that hemoglobin A1c. Yes.
So if this is a better indicator over the long term, why are fasting?
One, because it's quick. Two, it's cheaper. So we live in the real world, and that's why I tell you guys, you know, when you're testing, it's a perfect world, so you don't have to worry about money. You don't have to worry about time. You don't have to worry about equipment. You don't have to worry about staffing. And there's a fifth one. What's my fifth one? Time, money, equipment, staffing. Oh, come to me. So for testing purposes, it's a perfect world. But in real life, it's not. In real life, we're concerned about money. We're concerned about time. So usually what they do is if you don't meet those risk factors that I mentioned earlier, they just do a fasting blood glucose. Now, if that fasting blood glucose is elevated, then they'll take the next step of doing a hemoglobin A1c. Otherwise, they'll only order hemoglobin A1cs like if the person's overweight or, you know, they have a family history, things like that. But that's why, yeah.
Is it a requirement of the insurance company for payment?
Oh, yeah. The insurance company, they are the payers, so they run the show. That's not how it's supposed to be, but that's just the truth of the real world. What's that? Very sad. I could tell you guys stories. I used to work for Humana. I was a case manager, and whenever you are admitted into the hospital, you don't know this, but the minute that you are admitted, there's someone from the insurance company in the background. The minute you're admitted, they're notified, they're following your progression, and they go to the hospital to talk to the specialist, and they're like, let's get this patient out. What do we have to do? They will question orders. I kid you not. I kid you not. I was lucky enough that I had a great medical director. The medical director, like, he trusted me. And so let me tell you, I refuse to go into a hospital and say to a doctor that this test is unnecessary. We're not going to pay for it. Are you kidding me? Absolutely not. I have a conversation with the physician if it's a test and, you know, the diagnosis that the patient has, you know, I'm wondering, okay, why are we doing this test? I'll have a conversation to find out and it'll make sense. Okay, let's keep it moving. But let me tell you something. Every time you're admitted, someone in the background, they know that you're admitted and they're reaching out to the case manager at the hospital. They're reaching out to the physicians and the specialists that are following you to ask about certain tests that have been ordered and to basically, in a nice, gentle way, find out when you're getting out. What do we have to do to get this patient out of here?
Also, we're at in place to referral to Humana. That's the reason why Humana only lets choose their own doctors now, that you can't use your own doctor. So are those doctors influenced by Humana?
Oh, they're definitely influenced. And this is not only Humana, this is every insurance company.
Yeah.
Absolutely. Absolutely. And so there's a criteria depending on your diagnosis that, okay, person had an MI, they should be out within 3 to 4 days. So if they pass the 4th day, they're getting a phone call from a case manager of whichever that insurance company is and say, hey, what's going on with this patient? And the specialists say, okay, well, there were complications, blah, blah, blah. And the case manager be like, okay, well, can we get them to a rehab or a step down? Why do they still need to be on the floor? So they do have pressure because at the end of the day, they're the payers. All right, moving on. That was depressing, wasn't it? All right, diabetes. Type 1 diabetes is usually associated with, you guys need to know this, rapid onset, mostly in younger people, and is connected in many cases to viral destruction of the beta cells of the pancreas. Let's break this down. Type 1, usually associated with rapid onset, younger people. Type 1 used to be called juvenile, what do they used to call it? Juvenile onset diabetes, because we do tend to see it in the younger people. And what happens is they're thinking it's from a virus that destroyed that part of the pancreas. Remember, insulin is made by the beta cells in the ileus of Langerhans in the pancreas. Type 1 diabetes, what's this word say? Always. Remember, I told you when you are studying and you see those all-inclusive such as always, never, only, pay attention. They're most likely going to be a test question somewhere. Type 1 diabetes always requires insulin replacement because beta cells are no longer functioning. You better know this. If I give an oral hypoglycemic agent to a patient that is a type 1 diabetic, guess what? They're going to end up dying if they don't get insulin. Why? Because those oral hypoglycemic, but you better have some kind of working of a pancreas, right? We'll get into that when we talk about the oral hypoglycemics. Studies released in 2001 reported that the incidence of type 2 diabetes in teenagers and young adults is markedly increasing. The rise of fast food. Both parents now, for the most part, are working. So these kids are getting, instead of, fresh food being cooked at home, lots of fast food, their lunchbox being packed with lots of sugary foods. So they're seeing a lot of type 2 diabetes in younger children, where we used to see type 2 diabetes in older adults. And when I say older adults, because guys, it takes a while of eating those cookies and candies and chocolates and all that stuff before you're diabetic, right? It takes years and years. So we used to see it on the older people because they've had all of those years that accumulated of eating that. But we're seeing it at younger and younger and younger ages. Patients with type 2 diabetes are able to produce insulin, look at this, guys, but perhaps not enough to maintain glucose control. Or perhaps their insulin receptors are not sensitive enough to insulin, leading to increased serum glucose levels. So those patients with type 2 diabetes, they do have some functioning of that pancreas. And that pancreas may be working up to par, but the patient is eating so much of the sugary foods that the pancreas is like, you know what? I'm tired of you and your crap. I'm not giving 100% anymore because you're about to kill me. I'm only going to give 80%. And what happens is that patient, because most type 2 diabetic patients, most of them, when they start eating right, exercising, they don't have to be a diabetic. That hemoglobin A1c goes down and they are no longer diabetic. Once you are a type 2 diabetic, that doesn't mean you're going to be a type 2 diabetic forever. Because what happens is most diabetics, not all of them, but most of them, what happens is they start eating right, they start exercising, the pancreas wakes up. The pancreas is like, oh, okay, you want to be good to me now? I'll be good to you. So then the pancreas goes back from the 60 or 80 back to the 100. Okay? The treatment, if that doesn't work for the type 2 diabetic, we move on to still diet and exercise, but oral hypoglycemia. And then if that doesn't work, then the patient's going to have to go to insulin. When diet and exercise no longer work, other agents discussed later are tried to stimulate the production of insulin in the pancreas. Those are your oral hypoglycemic agents I mentioned. increased sensitivity of the insulin receptor sites, again, oral hypoglycemic agents, or control entry of glucose into the system. So these different actions, guys, those are different actions of the oral hypoglycemic agents that we'll be talking about shortly. Injection of insulin may, what does this word say? Eventually be needed. So they're letting us know that insulin add on oral hypoglycemic agents to the diet and exercise. And then if that doesn't work, then we're going to add on the insulin. Now, this is for the type 2 diabetics, because remember, the type 1 diabetics, there's only one treatment, which is what? Insulin. Very good. Let's take a look at this box, managing glucose levels during stress. The body has many compensatory mechanisms for ensuring that blood glucose levels stay within safe range. The sympathetic stress reaction elevates blood glucose levels to provide ready energy for the fight or flight. Stress reactions in severe stress situations, such as an acute myocardial infarction or a motor vehicle accident, the blood glucose level can be high, 300 to 400. Remember, guys, normal is 70 to 110. But when that patient is severely stressed, it can go high. The body uses that energy, because that's what glucose gives you, energy. The body uses that energy to fight the insult or flee from the stressor. The usual medical response to blood glucose concentration of 400 milligrams per deciliter would be the administration of insulin. We need to bring that blood glucose down immediately, right? Because the oral hypoglycemic agents, they take much longer to kick in. We don't have time for that. That patient's at 400, we need to bring that glucose down immediately. They're going to get insulin. Next page. Hyperglycemia. Remember, normal blood sugar is 70 to 110. Hyperglycemia, what did I write? Oh, hot and dry sugar too high. And if they're cool and clammy, they need some candy. So let's talk about hyperglycemia first. Hot and dry, sugar's too high, okay? Hyperglycemia, recent guidelines suggest fasting blood glucose of 126 or higher are indicative of diabetes mellitus, and levels between 100 and 125 are hyperglycemia or impaired fasting glucose levels. Clinical signs and symptoms include, you need to know these. These are your signs and symptoms that that patient's blood sugar is too high. Fatigue, lethargy, irritation, glycosuria, polyphagia, polydipsia, itchy skin. What is that itchy skin from? Look at this, accumulation of waste that the liver can't clear. Remember, when the body doesn't get the sugar, starts breaking down those proteins. The byproduct of that protein is what? The waste, the nitrous waste, okay? If hyperglycemia goes unchecked, the patient will experience, it doesn't say can, they will experience ketoacidosis and CNS changes that can progress to coma. Signs of impending dangerous complications of hyperglycemia include the following. Look at this, fruity breath as ketones build up in the system and are excreted through the lungs. That fruity breath and ketones, that's ketoacidosis. You need to know that. Dehydration as fluid and important electrolytes are lost through the kidneys. Slow, deep, all of these guys are signs and symptoms of ketoacidosis. Slow, deep respirations, these are known as your Kussmaul respirations, as the body tries to rid itself of the high acid levels. Remember, that blood sugar is so high, the body starts breaking down the fat and muscles. Patient has all this nitrous waste in their system, which is acidic, right? So the patient's trying to get rid of all this acid in the body. Remember, when it comes to acid-base balance, there's only two primary organs that can help, the lungs and the kidneys. The lungs are responsible for your carbon dioxide, and your kidneys are responsible for your bicarb, right? So the patient has all of this acid in their body and they're trying to get rid of the acid. What do? They start doing this. They're trying to breathe off all of that carbon dioxide because the carbon dioxide is acidic. When you think of carbon dioxide, think carbon diacid. So you can remember that carbon dioxide is acidic. So they start breathing, that's the small respirations to try to bring their body back to equilibrium because right now they're in a acidic state. Keto acid doses, keto from those ketones that are being spilled, acid, they're in an acidic state. Loss of orientation and coma. They can go into a coma if the hyperglycemia goes unchecked. Do you guys need a break before we go into hypoglycemia? No, you're good. Okay. So let's talk about hypoglycemia. Cool and clammy, they need candy. Thank you. And on the side here, I wrote orange juice is a fast-acting carb. So the patient has hypoglycemia. If they're awake, you know, they can swallow. We're not worrying about them aspirating. A great thing to give them some orange juice to get their blood sugar up quickly. That orange juice is going to be followed by a complex carb, but just to get that blood sugar up, because remember, hypoglycemia is much more deadly than hyperglycemia. So let's talk about hypoglycemia. Hypoglycemia, or blood glucose concentrations, low blood glucose concentrations of 70 or lower. Remember, our range is 70 to 110. Lower than 70, the patient's hypoglycemic. The initial reaction to falling blood glucose levels is parasympathetic stimulation. Increased GI activity to increase the digestion and absorption. Why? It's trying to get that glucose. Rather rapidly, the SNS responds with fight or flight reaction that increases blood glucose levels by initiating the breakdown of fat and glycogen to release glucose for rapid energy. Why? Because the body knows that hypoglycemia is way more deadly than hyperglycemia. So your body kicks in very quickly. The pancreas releases glucagon. Remember, glucagon is that stored form of glucose. The pancreas releases glucagon, a hormone that counters the effects of insulin to bring up that blood sugar. Take a look at table 38.1. You absolutely must know the difference between hyper and hypoglycemia, because you will get more than one test question telling you that that patient's a diabetic, and all they'll give you are the clinical manifestations, and you have to figure out what to do. You're going to know what to do by knowing if that patient is hyper or hypoglycemic. If the body releases glucagon and then you administer glucagon, will that produce hyperglycemia? I didn't hear the first part of your question. If your body's releasing glucagon and then you administer glucagon, will you end up in a hyperglycemic? Well, here's the thing. If we're administering that glucagon, that means they're hypoglycemic. So that means the body's not releasing enough of it anyway. Otherwise, we wouldn't have been given to it. So no. Now, there are times maybe the patient gets too much and that makes their blood sugar go up. But we would only give it if the blood sugar was low, which means the body wasn't releasing enough of it or they weren't doing it at all. All right, guys, signs and symptoms. Look at hypoglycemia for the CNS: headache, blurred vision, drowsiness, neuromuscular, weakness, muscle spasm, twitching, progressing to seizures, cardiovascular, normal to high blood pressure, tachycardia, respiratory, rapid, shallow respirations. Other, diaphoresis, they're going to be sweating, cool and clammy. Laboratory test, the urine for glucose is going to be negative. The blood glucose is going to be low. The onset for hypoglycemia, sudden. The patient appears anxious, nervous, confused. Let's move on to hyperglycemia. Rapid deep respirations, those are your small respirations. Acetone-like or fruity breath, that's your DKA. Nausea, vomiting, thirst, polydipsia. I think I write on the side. Oh, dilute. Oh, I wrote dilute to remind you that the body's trying to dilute all that sugar. Remember. Increased hunger, polyphagia. I wrote that in because it's not in the book, but you definitely will be tested on it. Dry, warm, flushed skin. The urine glucose, strongly positive, lots of sugar in the blood. Urine ketones, positive, high blood glucose. Increased urination, your polyuria. Yes.
So hypo and hyper both cause hunger.
Yes, but for the reasons are different. So hypoglycemia, they're hungry because they don't have blood glucose, so they're trying to get the glucose up. With hyperglycemia, the reason they're hungry, they have the blood, they have the glucose. The problem is it's stuck in the blood. So the tissues need the glucose. Does that make sense? So yes, they're both hungry, but the reason for the hunger is different. Hyperglycemia, they got the sugar, it's just stuck in the blood. Hypoglycemia, they don't have the sugar and they need it. Got it? Table 38.2. Insulin, the usual indications. Why would we give insulin? Make sure you know them. It says treatment of type 1 diabetes. Remember, they're insulin dependent. They have to get insulin. And type 2 diabetes in patients whose diabetes cannot be controlled by diet or other agents. Look at that sentence. That is just another way that they've reminded us that the type 2 diabetics are started with just diet and exercise. And then if that doesn't work, oral hypoglycemic. And then if that doesn't work, lastly, insulin. You see how they worded it? Pay attention to that, guys, because I'm not always going to be your instructor. But when you're reading and you're studying and you see the author telling you the same thing just in different ways, just know that's going to be a test question. You have a 98% chance of your instructor making a test question if it's instructor worth a grain of salt, okay? Oh, I'm going to have to cut that part out. Why else would we give insulin? Severe ketoacidosis or a diabetic coma. Obviously, we need to get that blood sugar down. By the way, if that patient's blood sugar is so high that they're in ketoacidosis or coma, we have to get the blood sugar down, but we have to do it slowly. Otherwise, we could cause other complications. So I know it sounds weird, but when their blood sugar is that high, we're giving them insulin, but we're also giving them glucose at the same time because we're trying to bring down the glucose, but not rapidly. We're trying to bring it down slowly. Okay. Why else would we give insulin? It's used for short courses of therapy during periods of stress. So if a diabetic patient who's never been insulin dependent, but now they're in the hospital, they're having surgery, or they have some type of disease, they may get insulin. It's going to be your job to teach them that, you know, this isn't forever. We can give insulin to gestational diabetes. If the woman is pregnant, she's never been diabetic before, but now that she's pregnant, she's diabetic, that's gestational diabetes. Okay? And when the woman's pregnant, she has gestational diabetes, she cannot take oral hypoglycemic. The only thing she can get is insulin. And the cure to gestational diabetes is delivering the baby, giving birth. Once the baby's out, she won't be diabetic anymore. But this is important for you guys to know. Any woman who has gestational diabetes, that automatically puts them in the group of risk factors for type 2 diabetes. Okay? For developing it down the road. Insulin. Insulin is the, what does that word say? Only. Insulin is the only parental anti-diabetic agent available for exogenous, as meaning outside, exogenous replacement of low levels of insulin. It's used to treat type 1 diabetes and to treat type 2 diabetes in adults who have no response. Oh my gosh, how many times have we seen this? To diet, exercise, and other hypoglycemic agents. A million times, a million ways, they've let you know the order for treatment of the diabetic patients.
Yes.
Pharmacokinetics. Injection sites need to be rotated regularly to avoid damage to muscles and prevent subcutaneous atrophy. So what you do, guys, you teach the patients to rotate sites, but in a week, for example, they're not going to do left subq arm, then right subq arm, then left abdomen. No, you teach them to rotate sites within one area first. So they'll rotate sites within one area of that subcutaneous area of the left arm, then the right arm, then the left side of the stomach, then the right side of the stomach. So you teach them to rotate sites within one area before they go on to the next, okay? Regular insulin is given IM or IV in emergency situations. Types of insulin used are determined by the anticipated eating and exercise activities of any particular patient. Insulin glargine, that's your Lantus, or Trujillo, I pronounced that wrong, but you know I made you see it, and insulin levemir, look at this, guys, cannot be mixed in solution with any other drug, including other insulins. You cannot mix long-acting insulins. Look at table 38.5. Let's take a break. I gotta run to the restroom. Let's take a break and we'll start here. 5 minutes. Okay, guys, box 38.5. Insulin delivery. Different ways the patient can get insulin. The subcutaneous route, and that's the route that most patients get their insulin. Insulin pen. That's a syringe-like device, and it looks like a pen. It has a small needle at the tip and a barrel that holds insulin. The patient dials the amount of insulin to be given and injects the insulin subcutaneously. That's how the insulin's given, guys, sub-Q, by pressing on the top of the pen. Now, this is a great option for older patients or patients with vision problems, right? Because they may not be able to draw up the correct amount of insulin. And let me tell you something, insulin will kill you very quickly if you take too much of it, right? So with the insulin pen, they can hear and feel the clicks to know how many units they're going to be giving themselves. This is advantageous for people who need insulin 2 or 3 times during the day, but cannot easily transport syringes and needles. So that's also good for people who, you know, don't want to carry all those needles around. But for testing purposes, when it comes to the insulin pen, they usually ask about the patient with the decreased vision. So they'll give you 4 types of patients and ask you who would benefit more from the insulin pen. It's important to rotate the syringe 15 to 20 times before injecting the insulin to dispense it. Another way the patient can get insulin IV, in emergency situations or when rapid and continual control of blood glucose is needed, insulin can be given IV. Insulin is considered a high-risk drug because it can kill you very quickly. It's considered a high-risk drug when administered this way. There's a potential for rapid changes in blood glucose and resultant risk to the CNS and the heart. Insulin should be given using a controlled delivery pump. When insulin is given IV, it has to be given on a pump. Okay? The patient should be constantly monitored and frequent blood glucose levels should be done. sorry,
How fast?
very fast. I don't know how many minutes, but very fast to kill you. Yeah, you plan on that.
No, I just wonder how fast I can get to the station.
Yeah, I don't know how long, but very quickly. Long-acting insulin, we're gonna be going over that. Inhaled insulin. On the top for inhaled insulin, I wrote, contraindications. So if the patient takes inhaled insulin, they cannot take it if they have a history of smoking or a history of lung disease. Inhaled insulin. There are warnings that problems could occur with people who have asthma, chronic obstructive pulmonary disease, or lung cancer, and a baseline appearance, and a baseline and periodic spirometry is suggested. We got to keep checking those lungs if the patient's getting the insulin inhaled. It is a rapid acting insulin inhaled at the beginning of a meal. So that inhaled insulin, it's rapid, long acting. What does it say? Rapid. And when's it taken? Okay. Focus on safe medication administration. Insulin's usually given subcutaneously. The areas of the body that are best able to be pinch up to access the tissue are the abdomen, and on the side I wrote, just be careful because with the and this is where we usually give it, but just remember with the abdomen we have the best absorption. Okay, the abdomen, upper thigh, and upper arm. Out of those three, you'll get the best absorption from the abdomen. I'm sorry?
What box?
What box? It doesn't say, it just says,
No, I mean, like, what figure is that?
oh, up there, 38.1. This one? Figure 38.1.
It doesn't have a number.
Yeah.
It just focus stage.
Found it? All right. You're going to insert the needle at a 45-degree angle and inject the insulin. Again, rotate sides regularly to prevent tissue damage. Because what happens is, if that patient keeps injecting themselves in that same spot over and over and over and over, that tissue starts to get hard. And guess what? The absorption gets decreased. And so they don't get enough of the insulin that they need. Contraindication precautions. Because insulin is used as a replacement hormone, there are no contraindications other than episodes of hypoglycemia. Obviously, if that patient's already hypoglycemic, why in the world would you give them insulin? So yes, hypoglycemia is a contraindication. Care should be taken during pregnancy. Care should be taken during pregnancy and lactation. Remember, if mom is pregnant, she can only get insulin. She cannot get oral hypoglycemic agents. Insulin does not cross the placenta. Therefore, look at this. It's the drug of choice for managing diabetes during pregnancy. You know, this entire semester, pregnancy's always been contraindicated, right? But when it comes to insulin, this is the drug of choice for the pregnant mom if she's diabetic. Insulin does enter breast milk, but is destroyed in the GI tract and does not affect the nursing infant. And that's why people can't take insulin orally. Because of the hydrochloric acid in their stomach, it destroys the insulin. Adverse effects. The most common adverse effects related to insulin use are hypoglycemia and ketoacidosis, which can be controlled with proper dose adjustments. Let me tell you guys this. When you guys get a test question about, they'll give you example, they'll tell you the patient's diagnosis and the patient's on a medication. 90% of the time, the reason they are mentioning that medication is because they're asking you what is either a nursing intervention for that medication, what is an adverse effect of that medication, and the third one, which they don't ask very often, but sometimes they do, an indication. Remember, guys, when it comes to adverse effects of medication, that includes what happens if this medication works a little bit too well. So we're giving that insulin to lower that blood sugar. But if that insulin works a little too well, it can cause a hypoglycemic reaction. Okay? Other adverse effects, lipodystrophy. This is this is lessened by rotation of injection sites. So that lipodystrophy, that's that hardening of the tissue I was telling you about. And then when that tissue gets hard because the person keeps injecting themselves in the same area, the absorption is decreased. With inhaled insulin, the most common adverse effects also include cough and throat pain or irritation. Next page. Everything okay?
Our books don't say keto.
Mine does.
Your book doesn't say keto
So
acid.
it says hypoglycemia and ketoacidosis are, some of us are missing.
Are you kidding me?
No, I had to write it in.
Same, yeah.
Wow.
Mine.
Make sure you guys know this because I will test you on it. I'm gonna kill you on diabetes. I'm telling you this now. You better be studying hard. That's gonna be half of your final next week.
Makes it 24?
What's that?
No, that's good search.
Oh, just kidding.
Yeah, you have 100 questions next week.
Yeah.
And half of them are gonna be diabetes.
Like on paper?
All right, drug-drug interactions. Caution should be used when giving a patient stabilized on insulin, any drug that decreases glucose levels, and that makes sense. If we're giving that patient insulin and we know that lowers the blood sugar, why would we give them anything else that would also lower the blood sugar? And we know hypoglycemia will kill you a lot faster than hyperglycemia. Think about it. Hypoglycemia, your blood sugar drops, boom, you're on the ground. But hyperglycemia, you start getting thirsty, you're trying to dilute the urine, you start drinking a lot, right? You start urinating all over the place, right? You start being hungry, trying to eat a lot. So your body has these mechanisms to try to save you when you're hyperglycemic. But boy, oh boy, when you're hypoglycemic, that's it, you're done. You know what I mean? So examples that they're giving you, that they're telling you can cause drug-drug interactions that we don't want to give to a patient with that's taking insulin. Excuse me. MAOIs, beta blockers, salicylates, alcohol. Care should also be taken when combining insulin with any beta blocker. Oh, that's interesting because they just told us up here not to give beta blocker with insulin. And now we're seeing it again down here. The blocking of the SNS also blocks many of the signs and symptoms of hypoglycemia. Beta blockers block those signs and symptoms of hyperglycemia. They hinder the patient's ability to recognize problems. Patients taking beta blockers need to learn other ways to recognize hypoglycemia with various herbal therapies. They have to talk to their doctor before, or their healthcare provider before they take any teas or herbs. Box 38.6. Patients being treated with anti-diabetic therapies are at increased risk for developing hypoglycemia if they use juniper berries, ginseng, garlic, fenugreek, coriander, dandelion root, or celery. Down here, I wrote, if a patient tells you they're taking any of these, find out if they're on any anti-diabetic meds. Adpi. So if they tell you that they're taking any of these mentioned, guys, the ginseng, the juniper berries, all of these I mentioned, if you have a diabetic patient telling you that they take any of these, the first thing that you need to ask them is, are they on any anti-diabetic agents? Are they on insulin, or are they on any oral hypoglycemic agents? ADPI, always assess first. Ask questions, get information. All right, guys, you see this? This is going to be the basis of so many questions that you guys have next week for your final. Make sure that you understand it. So this, I don't know which one to call it, it's not a box, but I'll call it box just for this purpose. It gives you the insulins, the onset, the peaks, and the duration. Next to onset. Next to onset, I want you to write or remember. The onset lets you know when this insulin starts to work. That tells you when you need to feed the patient.
Right, starts.
Yeah. It tells you when that insulin starts to work. It tells you when you need to feed that patient. So if you get a test question and, they're talking about the diabetic patient, they're taking this type of insulin. From the type of insulin that they're taking, that onset, which you have to memorize, you have to know what that onset is. That onset tells you when you feed the patient. So they'll give you the type of insulin and then ask you when would you feed the patient? Well, we feed the patient at the onset. The peak. The peak tells you the most dangerous time that you need to check on that patient. Because look at me guys, eyes on me. The peak of the insulin is when the blood sugar is the lowest. And remember, hypoglycemia is more deadly than hyperglycemia. And as nursing students, you guys get this confused all the time because when you think of peak, you think of high. But the peak of insulin is when their blood sugar is the highest. It's when the insulin itself is working the most, which means the blood sugar is the lowest. That is the most dangerous time where that patient can fall out on you. So the peak of an insulin tells you when you better be checking on that patient, when we expect their blood sugar to possibly be the lowest, right?
Blood sugar is lowest, but the insulin is at the highest.
Exactly. Duration. I'm sorry? I didn't hear what you said,
I
Lauren.
just wanna, hold on one second, I'm running it all down.
Oh, okay. All right, just to recap, the onset, that tells you when that insulin starts to work, when you have to feed that patient, right? The peak tells you the most dangerous time that that patient might bottom out on you, so you need to check them. The peak of the insulin is when that insulin is working the best and the patient's blood sugar can be the lowest, right? And lastly, the duration. The duration is how long the insulin is working for. So that duration tells you the next time that patient would need an injection. If you can wrap this around your brain, guys, you're going to kill those diabetes questions, because that's how come students always get it wrong, because they don't understand when you get a test question and it asks you when would be a priority to check on the patient. What they're really asking you is what's the peak time of that insulin that you just gave. When they ask you, when would you feed this patient? What they're really asking you is, what's the onset of this insulin? When they ask you, when do you expect the next dose to be given? What they're really asking you is, what's the duration of this insulin? You guys got it? Mm-hmm. All right. Now, on the side over here, you're so lucky. You're so lucky because you guys are so lazy and I don't trust you to do it. So I did it for you. You're welcome. You absolutely must know which insulins are long acting versus rapid fast versus intermediate. Okay. So your regular insulin, that's your regular insulin, regular acting. Your NPH, that is intermediate. Your inhaled insulin, that's rapid or fast acting. Your Lispro, that's rapid or fast acting. Your Aspart, that is rapid or fast acting. Your Glargine, that is long acting. And remember, long acting insulins, can they ever be mixed with anything? No.
Both Glargines.
Yes, both of Glargines, your Lantus and your Trugio, they're both long acting, cannot be mixed with anything. Glulisamine, that's your rapid fast acting. Detamere, your Levemir, that is long acting. You guys got to know your insulins. You got to know if they're rapid acting, intermediate, long, and you have to know the onset, the peak, and the duration.
What did you, no, what did you write over?
What did I write over duration? How long good? How long the insulin works for, so you know when's the next time you have to give the next dosage.
Why is the why do they?
Because it's long acting. So she after the oh, that was the only one. The other two I can tell you because it's long acting. What it does is, you know how most of the insulins, so you give it right, and it has the peak, and then it goes back down. With the long acting, it works over 24 hours, so it stays the same. There's never a peak, except for your Detamere. But with the other two, it's just the way your body, does it, shoots out insulin in the same amount, except when you eat a meal, it goes high and then down. But the long acting, the purpose of it is just to give you just a little bit all the time, just to keep you at a steady level. The last one, I don't know though. I don't know why.
It's just the exception.
What's that?
It's like the exception to the rule.
Yes, it's exception to the rule. There's always an exception to the rule. All right, nursing considerations for patients taking insulin. By the way, don't forget these adverse effects. We've gone over them already. Make sure you know them. Okay, nursing considerations for patients taking insulin. You're going to assess them for obviously any allergy to insulin, the current status of pregnancy, lactation. Assess them for a history of asthma or COPD if they plan on taking an inhaled insulin. You're going to do a physical assessment on the patient to get a baseline. Spirometry, if the patient's taking the inhaled form, remember we have to keep an eye on the lungs. By the way, I skipped this. Make sure you know important nursing diagnoses that you expect that patient to have when they're taking insulin. Implementation rationale. Make sure that the patient is following the diet and exercise. That is the first thing we tell them to do. Proper diet and exercise. Make sure that they're using good hygiene practices. Remember, patients who are hyperglycemic are at increased risk for infection. Gently rotate the vial containing the agent and avoid vigorous shaking. So guys, you roll the vial like this, right? You don't shake it, you roll the vial. Rotate injection sites regularly. Give regular insulin, IM or IV in emergency situations. Monitor the patient for signs and symptoms of hypoglycemia, especially during what times? Peak times. During the peak time of the insulin, that's when you expect that patient to have hypoglycemia. Always verify the name of the insulin being given. Use caution when mixing insulin types. Storage. Store insulin in a cool place away from direct sunlight, so you can't have that vial on a windowsill, guys. Pre-drawn syringes are stable for 1 week if refrigerated. Monitor the patient during times of trauma or severe stress. During times of trauma or severe stress, do we expect the blood glucose to be higher or lower? Higher, very good. Monitor patient's food intake. Ensure that the patient eats when using insulin. Very important. You do not want to give insulin to a patient that hasn't eaten or is not eating. You will throw them into a hypoglycemic state. Monitor the, wait, let me back up because this is important. Remember, if it's not documented, it didn't happen. So you better make sure you also document, when you document that you gave whatever units to the patient of insulin, you better make sure that you document how much of the meal that they had to prove that you know they ate. You didn't just give that insulin to the patient and they haven't eaten yet. They had a hypoglycemic reaction. It's not your fault. Make sure you cover yourself. Monitor the patient's exercise and activities. Ensure that the patient considers the effects of exercise in relationship to eating and insulin dose. That's important. So if the patient is going to exercise, that can lower the blood glucose, right? If the patient's going to eat, that can increase the blood glucose. So you make sure that the patient knows that relationship. Protect the patient from infection. Remember, they're at risk for infection, including good skin care and foot care. You want to screen for injuries. Warning signs of problems, including signs and symptoms of hypoglycemia and hyperglycemia. The importance of increased screening when ill or unable to eat properly. They need to know that. If you're sick, your blood sugar is going to go up or down. You guys are killing me. If you're sick, remember that's a stress on the body. So the blood sugar is going to go up. You're killing me. If you're unable to eat, is your blood sugar going to go up or down? Down. So this is very important that you teach them, or that they need to be seen by the healthcare provider if something's going on with them, they're not eating, or they're sick. Because either way, the regimen may have to be changed. Teach the patient to never reuse needles or share needles with other people, and the need to monitor disease status. Next page. All right, Mr. MJ, I'm assuming he's a type 1 diabetic. We're going to teach him diet modifications and increased exercise are important aspects of your diabetes management. Now remember, they're type 1 diabetic. So besides this diet and exercise, which is wonderful, what is the primary thing we need to make sure that patient's getting? Insulin. Very good. We're going to teach them to practice good skincare and hygiene measures. We're going to teach them to check for any injury or sign of infection because they are at risk for infections, right? And remember, they don't heal quickly. By injecting insulin each day, you can help your body use the sugars and fats in your food effectively. The stuff you're teaching the patient. You're going to teach them to store the insulin at room temperature and stay away from extremes of heat and light. Gently rotate, not shake. Gently rotate the vial between your palms before used to disperse any crystals that may have formed. Do not shake. Do not shake the vial because vigorous shaking can inactivate the drug. Rotate your injection sites on a regular basis. And remember, we're going to rotate in one area before you move on to the next. Rotate your injection sites regularly to prevent tissue damage and to ensure that proper amount of insulin is absorbed. Never reuse needles and never share needles with other people. You should be aware of the signs and symptoms of hypoglycemia when you take too much insulin. If this occurs, look at this, eat or drink something high in sugar, such as candy, orange juice, honey, or sugar. Those are fast-acting sugars to bring up the blood sugar immediately. The signs and symptoms to watch for include nervousness, anxiety, sweating, pale and cool skin, headache, nausea, hunger, shakiness. So this is the second time that we're seeing those signs and symptoms of hypoglycemia. These may happen if you skip a meal, exercise too much, or experience extreme stress. If these symptoms happen often, notify your healthcare provider. And the reason for that, if it's happening often, that means whatever regimen that patient's on is not working. So it's going to have to be adjusted. If you cannot eat because of illness or other problems, it's the second time we're seeing this, guys, do not take your usual insulin dose. How are you going to take insulin you haven't eaten? Contact your healthcare provider for assistance. Next page. Avoid the use of over-the-counter medications or herbal therapies without first checking with your healthcare provider. Avoid the use of alcohol because it increases the chance of having hypoglycemic reactions. That patient that's a diabetic, teach them to wear a medical alert bracelet. So if they pass out, someone sees that bracelet, don't know they're diabetic. Most likely that patient's having a hypoglycemic reaction. Report any of these to your healthcare provider. Loss of appetite, blurred vision, fruity odor, fruity breath, increased urination, increased thirst, nausea, vomiting. Keep your regular medical follow-ups, including blood tests. Keep this drug and your syringes out of the reach of children. Do not give this medication to anyone else or take any similar medication that has not been prescribed to you. Key points. Insulin replaces the endogenous, that means naturally occurring within the body. Insulin replaces the endogenous hormone when the body does not produce enough insulin or when there's not enough insulin receptor sites to provide adequate glucose control. Blood glucose levels vary with food intake, exercise, and stress levels. Patients need to learn to recognize the signs of hypo and hyperglycemia. All right, so now let's move on to our hypoglycemic agents. We're going to start with the sulfonylureas and other anti-diabetic agents. On the side, I wrote metabolized by liver. So you need to be checking that patient's liver function studies. All right, sulfonylureas and other anti-diabetic agents. These agents include the sulfonylureas and other anti-diabetic agents. Look at this, guys. They stimulate the pancreas to release insulin. This is very important. And that's why we cannot give a sulfonylurea to a type 1 diabetic. Because let me tell you what the sulfonylurea does. Let's say he's the pancreas. I'm the sulfonylurea. What the sulfonylurea does is say, hey, wake up, start shooting out insulin, do your job. Well, the type 1 diabetic, that pancreas is dead. So by the time that thing starts working, that patient's gonna be 6 feet under. So the sulfonylureas push the pancreas to wake up and start shooting out insulin. That means if a patient's taking a sulfonylurea, they have to have a functioning pancreas, right? Okay. Page 648, sulfonylureas. The sulfonylureas bind to potassium channels on the pancreatic beta cells. They are effective only, oh, there goes all-inclusive again. They are effective only in patients who have functioning beta cells. They are not effective for all diabetic patients and may lose their effectiveness over time with others. Because there are some diabetic patients that have been, diabetic for so long and their blood sugar's been chronically high for so long, that pancreas is done, kaput, forget it, right? So those type of patients, the sulfonylureas aren't going to work on them because the sulfonylurea will be saying, hey, wake up all day, and the pancreas does nothing. First generation sulfonylureas, make sure you know this list, guys. Chloropropylmine, it has the most predictable effects and has been proven reliable. Probutamide is preferred for patients with renal dysfunction who may not be able to excrete the chloropropylmine because it's more easily cleared from the body. Talazomide, which is used less frequently, is usually tried after the first 2 drugs have been shown ineffectively. So this drug, the talazomide, we only try this if the prochloromide or the probutamide is not working. The first generation sulfonylureas were associated with increased risk of cardiovascular disease and death in a somewhat controversial study. They are now thought to possibly cause an increase in cardiovascular death. Second generation sulfonylureas. The second generation sulfonylurea drugs include, make sure you guys know this list, They have several advantages over the first generation drugs, including, make sure you know this list, but the first one I'll go over, look at this, they're excreted in the urine and bile, making them safer for patients who have kidney problems. Therapeutic actions and indications. The sulfonylureas, again, the second time or third time we're seeing this. The sulfonylureas stimulate insulin release from the beta cells of the pancreas, which means the pancreas has to be functioning properly. They're indicated as an adjunct to diet and exercise to lower blood glucose levels in type 2 diabetes mellitus. And that goes across the board for all the oral hypoglycemic agents. Any oral hypoglycemic agent that the patient taking, they're taking that medication in addition to diet and exercise. We never tell them to stop dieting and exercising just to take the medication, okay? So you can get a test question about a patient saying, oh, I'm so happy I'm on this med, now I don't have to worry about my diet or exercise. No, you have to teach the patient that's wrong. You still have to diet and exercise. Contraindications and cautions to sulfonylureas. Obviously, if the patient has any allergy to sulfonylurea, you're not going to give it. Diabetes is complicated by fever, severe infection, severe trauma, major surgery, ketoacidosis, severe renal or hepatic disease, pregnancy, lactation. All of those are contraindications. Patient have any of these going on, they're going to get insulin. And look at this, contraindicated in type 1 diabetes. You better know that. We are not giving any of these oral hypoglycemics to our type 1 diabetic. They're getting insulin. That's why it's called insulin-dependent diabetes. These drugs are not for use during pregnancy. Remember, during pregnancy, they're going to get insulin. Insulin should be used if an anti-diabetic agent is needed during pregnancy. And we're not going to give sulfonylureas during lactation. Patient's going to get, if they're breastfeeding, they're going to get insulin. All right, adverse effects of the sulfonylureas. The most common adverse effects related to the sulfonylureas are hypoglycemia. That medication might work a little bit too well, and we threw them into hypoglycemic state. Make sure the patient takes with food to avoid this. GI distress, including nausea, vomiting, epigastric discomfort, heartburn, anorexia. Anorexia should be monitored because remember, guys, not wanting to eat, that can make your blood sugar go low, right? Anorexia should be monitored because affected patients may not eat after taking sulfonylurea, which could lead to hypoglycemia. And you see, I put a big sad face there to remind you that's bad. Allergic skin reactions have been reported with some drugs, increased risk of cardiovascular mortality. It didn't even say morbidity. Morbidity is illness, mortality is death. Cardiovascular mortality, particularly with the first generation agents. Drug-drug interactions. Any drug that acidifies the urine because excretion of the sulfonylureas may be decreased. We don't want the patient to have a toxic level of the sulfonylureas in their bloodstream. That'll cause what? Hypoglycemic reaction. Caution should also be used with beta blockers. Oh, there goes those beta blockers again. Caution should also be used with beta blockers, which mask the signs and symptoms of hypoglycemia. Cool and clammy, need some candy. And with alcohol, which can lead to altered glucose levels. Remember, guys, alcohol can cause hypoglycemia as well. Herbal therapies. You got to teach that patient they should not be taking any herbal therapies. They got to talk to their healthcare provider about it. Yes.
You said alcohol lowers blood sugar?
Yes. Other anti-diabetic agents, make sure you know those other anti-diabetic agents. Acarbose and miglitol. Those are inhibitors of alpha glucosidase. They delay the absorption of glucose. If the absorption of glucose is decreased, their blood sugar will be decreased. It makes sense. They've been associated with, what's that word in front of hepatic toxicity? Severe hepatic toxicity. Pay attention whenever you see that word severe in front of something. They could have just wrote hepatic toxicity, but they wrote severe hepatic toxicity for a reason. So the patient absolutely has to be on this drug. You better be monitoring those LFTs. You better be looking at the ALT, the AST, and looking to see how that liver is doing. Metformin. Metformin decreases the production and increases the uptake of glucose. It's effective in lowering blood glucose levels and does not cause hypoglycemia like the sulfonylureas do. It's been associated with the development of lactic acidosis. They're right here on the side. I wrote it decreases glucose production in the liver. Next page. The thiazolidines, I totally pronounced that incorrectly, but you see what I'm talking about. That class of drugs, okay? These are drugs that decrease insulin resistance. Some patients that have been diabetic for a very long time, the pancreas may be functioning properly. It's making the insulin that the body needs, but the tissues are now resistant to that insulin. Okay, so this class of drugs decrease that resistance to the insulin. Black box warning that there's increased risk of signs of heart failure when the medication is contraindicated in patients with moderate to severe heart failure. So we're not going to give this to any patient with, even if they have mild heart failure. Proglitazone has been strongly linked to an increased risk of bladder cancer if it's used for over a year. All patients, there goes another all-inclusive, everyone, all patients taking either drug should be screened for signs and symptoms of heart failure. Patients with pre-existing diagnosis of heart failure should not be started on these medications. Patients should also still be monitored for any change in liver function while they're taking these drugs. Page 653. I'm shocked Matthew hasn't called yet.
Maybe he's in the
Doubt that, but we'll see. All right. Nursing considerations for patients taking other anti-diabetic agents. You're going to assess them for allergy. You're going to assess them for severe renal hepatic dysfunction. You're going to assess their status of pregnancy and lactation. Remember, if they're pregnant or they're breastfeeding, they can only get insulin. You're going to do a physical assessment to get baseline on your patient. Assess for any skin lesions. Take vitals, get blood pressure, heart sounds. Implementation and rationale. Ensure the patient following diet and exercise modifications. Monitor their nutritional status. They need to be eating. Monitor the response carefully. Blood glucose monitoring is the most effective way. Monitor liver enzymes of patients receiving pioglitazone or I hate that I get so tongue-tied. I hate it. Rosiglitazone. And on the bottom, guys, I wrote oral anti-diabetics are hard on the liver, all of them. Yes, ma'am.
The nursing diagnosis.
Yes, you need to know them, but they're the same as the other oral hypoglycemic agents. But yes, you need to know them. Whose pencil did I borrow so I don't steal it? Okay. Monitor patients during times of trauma. We expect blood sugar to go up. Pregnancy or severe stress. Provide thorough patient teaching. Teach them how to properly dispose of needles and syringes in the red sharps bucket. Teach them the need for food intake. Teach them the signs and symptoms of hypo and hyperglycemia. Skin assessment, including daily inspection of the feet. That's very important, guys, because one tiny little cut on their feet, you're gonna teach them to inspect their feet daily. And physically, they cannot inspect their feet, have someone do it for them. Or they can use a mirror to look at the bottom of their feet, because one tiny little cut can turn into a huge infection. Before you know it, they've got to get that extremity amputated. Teach them signs and symptoms to report immediately. Measures to use when ill or unable to eat. Teach proper diet and exercise. Hygiene measures. Schedule follow visits and make sure they keep those visits. Key points. So ureas work only if the pancreas is functioning. And to be specific, those beta cells in the pancreas. In times of severe stress, patients regulated on other anti-diabetic agents usually need to be switched to insulin to control glucose levels. And once that stress is over, they can go back to their oral hypoglycemic agents. Proper diet and exercise are the backbone of anti-diabetic therapy. We never get rid of that. Anti-diabetic drugs are adjuncts, not replacement to diet and exercise. All right, let's talk about glucose elevating agents. Are you guys good or you need a break? Good? All right. Okay. So now we're switching gears. We're talking about agents that actually increase the blood glucose. Glucose elevating agents, as the name implies, raises blood glucose when hypoglycemia occurs. Remember, normal is 70 to 110. So less than 70, we may have to give the patient something to increase the blood glucose. Two agents are used to elevate glucose in these conditions. This is your diazoxide and glucagon. Pure glucose can also be given orally or IV to increase the glucose levels. Oral glucose tablets or gels included. You guys take a look at that, make sure you know it. They're available over the counter for patients to keep on hand for the management of moderate hypoglycemic episodes, because they're supposed to know those signs and symptoms of hypoglycemia. So once they have that and they're not able to test their blood sugar, but they recognize those symptoms, they can pop a sugar tablet. Yes.
Is that what they give to patients in the hospital when they're hypoglycemic? The little like
Yes, as long as that patient's alert. Yes. Therapeutic agents and indications. These agents increase the blood glucose level by decreasing insulin release and accelerating the breakdown of glycogen. Remember, that's your stored sugar, the glycogen in the liver to release glucose. They're indicated for the treatment of hypoglycemic reactions. Pharmacokinetics. Diazoxide is administered orally. Glucagon is given parentally only, and is the preferred agent for emergency situations. That is very important for you guys to know, the glucagon. So we give it parentally. Remember, guys, we have enteral and parental. Enteral is something that we use the GI tract, so it goes like by mouth. The GI tract is involved, right? But parental, we bypass that GI tract. So it's given parentally, and it's the preferred agent for emergency situations. It's going to be injected. Diazoxide is contraindicated to anyone with known allergies. Look at this, to sulfonamides or thiazides. It's contraindicated in pregnancy. There are no adequate studies on glucagon and pregnancy, so you should be reserved for the situations in which the benefits to the mother outweigh the risk to the fetus. Caution should be used during lactation. Caution should be used in patients with renal or hepatic dysfunction or cardiovascular disease. Adverse effects. Glucagon is associated with GI upset. Diazoxide has been associated with vascular effects, heart failure, and arrhythmias. Drug-drug interactions. Taking diazoxide in combination with thiazide diuretics causes increased risk of toxicity. Increased anticoagulation effects have been noted when glucagon is combined with oral anticoagulants. Make sure you know the adverse effects. Nursing considerations for patients taking glucose elevating agents. We're going to assess them for contraindications and cautions, such as allergy to thiazide if they're taking diazoxide. We're gonna assess them for hepatic dysfunction, cardiovascular disease, current status of pregnancy and lactation. We're gonna do a physical assessment on the patient to get a baseline, including vital signs. We're going to monitor patients' blood glucose. We're gonna monitor the results of the lab tests. Make sure you know these nursing diagnoses associated with the drugs given to elevate the patient's blood sugar. Implementation rationale. Monitor blood glucose levels. Look at this. Have insulin on standby during emergency use. What if it works a little bit too well? Monitor patients receiving diazoxide for potential cardiovascular effects, including blood pressure, heart rhythm, output, and weight changes. Provide thorough patient teaching. Make sure you go over these patient teaching. Summary. Treatment of diabetes involves control of blood glucose levels using diet and exercise, a combination of other agents to stimulate insulin release, or alter glucose absorption or the injection of replacement insulin. The amount and type of insulin given must be regulated daily. Insulin is used for type 1 diabetes always, and for type 2 diabetes in times of stress or when other therapies have failed. Remember, when it comes to the type 2, the insulin is our last measure. Other anti-diabetic agents include first and second generation sulfonylureas, which stimulate the pancreas to release insulin. Glucose elevating agents are used to increase glucose when levels become dangerously low. That's it, guys.